Hey, how's everybody doing today? I hope you had a great weekend. You know what day it is? Technical Tip Tuesday. I actually had a different case ready for you, but I came across this interesting case yesterday that in all my years of scanning, I don't think I've actually seen this to this degree. A couple weeks ago, I talked to you about the importance of collaterals in lower extremity arteries. This is collaterals 2. Before we get started on the case, I'd like to just take a minute and say thank you to all the subscribers, our new ones, as well as in particular our day 1 subscribers. We sure like the comments, any likes. If you have an interesting case, let us know. We'd be glad to put it up. So let's talk a little bit about the patient history and physical exam. He was a 70-year-old male. He was actually referred to us by a podiatrist. He was a pretty poor historian with severe dementia, and so we really had limited history. Apparently, he did have a history of peripheral arterial disease, and as I found out in the performing the examination, he had had prior intervention. He had a 2-month history of a non-healing left great toe ulceration, or that was the indication on the order. However, upon inspection, I noticed this involved not only the great toe, but also the second toe and part of the forefoot. He did have palpable femoral pulse, but absent left popliteal and ankle pulses. Let's go to the duplex scan. We started at the common femoral. Has a pretty reasonable waveform, little bit of flow disturbance there. You can also see a widely patent deep femoral artery and a pretty normal waveform in the deep femoral. We still have a multiphasic waveform in the proximal superficial femoral artery. And as I scan down in the mid segment, there you see some calcific disease. Doesn't really seem to be any significant or flow limiting stenosis at that point. As we get into the mid to distal superficial femoral artery, there's more disease. Here's a lesion probably approaching that flow limiting or 50% cutoff. We see almost a 2-to-1 velocity increase through this little segment here. Now the patient's not really all that cooperative, moving around a whole lot. As I get into the distal superficial femoral artery, a little bit difficult to image, but basically it looks like a dead end. I can't really follow the flow much further than this. Significantly dampened waveform. So I'm suspecting SFA occlusion. So I roll the patient over to get a little better look at the popliteal, and you can pick up those bright walls with that cross-hatching. This is the first I realized the patient had had an intervention. Here's a completely occluded popliteal stent. This actually extended into the distal popliteal. Now, I usually like to evaluate the tibial peroneal trunk from a posterior approach or posterior lateral approach. However, again, this patient was somewhat uncooperative. I wasn't able to see it very well. I roll him back over. I look at the origin of the anterior tibial, just lateral to the tibial tuberosity. Wow, check this out. I have an inflow collateral coming in from the left. It splits off into the anterior tibial and carries blood down the foot, and also retrograde flow back up that short proximal segment of the anterior tibial back into the tibial peroneal trunk. Pretty fascinating. Here's just a little bit different plane. I don't see the inflow collateral as well, but I can pick up the retrograde flow through that short segment of the anterior tibial and then curves around and actually supplies the tibial peroneal trunk. Of course, it's best practice to document or confirm all Doppler changes with the spectral analysis. Here we see the antegrade flow up that anterior tibial artery distal to the collateral, and we can confirm the retrograde flow in that short segment of the proximal anterior tibial, supplying blood down to the tibial peroneal trunk. Significantly dampened waveforms. Actually, all the runoff vessels were pretty good. Here's the posterior tibial artery. Pretty widely patent, little medial calcification, but look at that waveform, almost non-pulsatile. Here's the anterior tibial in the mid to distal part of the lower leg, and a spectral waveform from the dorsalis pedis, highly abnormal. And the peroneal artery, this is kind of in the mid to distal lower leg. Again, reasonable diameter vessel, but again, highly abnormal spectral waveform. And this is really the reason I'm presenting this case. How cool is this little video clip? We can clearly see that very prominent inflow collateral into the proximal anterior tibial, supplying the distal anterior tibial and ultimately the foot. We can see that retrograde flow up that proximal segment of the anterior tibial, which supplies the trunk, and ultimately the posterior tibial and the peroneal as well. To interpret this, you really have to pay attention to the angle of insination and the color bar, flow towards or away from the transducer. Don't be fooled by this vein right here. So how about that? That one little collateral supplying the entire lower leg and the foot. However, obviously not enough collateral flow. Actually, I was not able to take toe pressures on this individual. PPG wouldn't work, too much motion, as well as the ulceration on the toe. The ankle pressure was about 40. Certainly, this is ischemic ulceration. Hope you enjoyed. Remember, like, subscribe. If you need any Category 1 CME, please visit virtualveincenter.com. See you next Tuesday.